Tamburro. Her talk is entitled, What's New in the Medical Treatment of Vascular Malformations?
I want to start by thanking Dr. Pape, Dr. Rampazzo, and Dr. Basiri for inviting me. And I think I'm the only one with a question in my title, so hopefully there's an answer by the end. So I have no financial disclosures. I will discuss off-label use of medications. I also want you to know that I want to disclose that I have been part of 3 vascular anomalies team starting in the early 2000s in Riley Children's Hospital. Then I went to Rainbows and now here, and it's really one of the best parts of my career is to work interdisciplinary, and hopefully you all get to do that. So the answer is in the genes. The ability to have this discussion today is because we have pushed the genetics of our vascular malformations. Until we had better understanding of the why, there was no way we were going to be able to talk about medications. Of course, as I present today, this is just the beginning, but it's fairly exciting. One, I think I have more of a role on the vascular anomalies team, and I hope that I contribute and that we can provide better care for patients. So as you know, many teams, but Dr. Kula is here, has pushed the genetics, and this review is perfect and I think really gets you up to date on where we're at with the genetics, and it is critical then to understand why the medications we're using are working. Big, messy slide, right? Nobody likes these. But what is nice is that we can see that they are hitting along very similar pathways. And that, of course, we should have known, it's all about proliferation and cell growth, and that we do not have these cells being monitored like other cells. And especially as we talk about angiogenesis, it's just gone amok. And so we'll break this down into a little more detail. We're going to go over capillary, venous, and lymphatic malformations, and also arterial venous malformations. I tried to hit the gene defects, I think, that are hitting the largest number of these patients, and then reviewing the medications that will work. So as you know, ISVA came out with their classifications again this spring, and we will review the capillary malformations. And being a dermatologist, I have to show slides of photos of patients. So this is a capillary malformation of the typical distribution where we would worry about Sturge-Weber. Next, we have our venous malformations, and I'm going to go more toward the PIK3CA, and I will tell you one of the reasons is that our overgrowth patients are most difficult and problematic to treat. So as we gain more information about them, which is our typical PIK3CA gene defect, we'll be able to provide better care. So here's a more typical venous malformation that you all have dealt with. As you know, here at the mouth is very problematic, can be difficult to treat, but with our interdisciplinary teams, we usually do very well. Next step is talking about lymphatic malformations, and once again, these are cause a huge amount of comorbidity to patients, and they have suffered for years, and we really need to push forward and help them out. Once again, our most common one is the PIK3CA, so our medication, as we'll talk about, sirolimus, really hits a lot of our vascular malformations. And as you see here, I don't want you to think at any point, oh, I'm going to be able to treat all these medically and we won't need you surgeons. I think it's going to be a combination. I think it's going to be surgery, it's going to be interventional radiology and medications. And what we hope, as you know, is once we have it fairly under control, it's much smaller, livable, the morbidity is less, then we can use medications to keep them at that level. And then the last would be our arterial venous malformations. And I'm going to hit hard on the RASA1. And as you can see here, it's the same as the lymphatic malformations. It's going to take more than just medication, but I do think it's going to benefit these patients. So we're going to start with capillary malformation, and wonderful for us to know now that the GNAC ARG183 is a somatic mutation that causes Sturge-Weber and our isolated port wine stains. This gene defect will stop the cell from going to an inactive state, leading to proliferative endothelial cells. So our number one medication we're going to talk about, and as you can see, we lean on heavily now, is sirolimus. And just to give you some background, it was first discovered in Easter Island, and it's produced by bacteria. It was named after the native island Rapa Nui, so thus rapamycin. It's actually a macrolide for the mycin part. It was originally developed to be an antifungal. That didn't work so well, so then it looked into being an immunosuppressant. As you know, in 1999, it was approved for that and is used in many of our transplant patients. So the mechanism of action for sirolimus is to bind to the systolic protein FK binding. This FK binding protein 12 is a complex that will inhibit mTOR. And you know that name came from this medicine, the mammalian target of rapamycin. And rapamycin is our other name for sirolimus. So this pathway is directly binded by the mTOR complex 1. Why is that important? Well, your mTOR complex 1 controls protein synthesis, proliferation, growth, and that's why these cells are moving forward in that manner. Here's a schematic where you can see sirolimus is binding there to FKBP12. And then as you can see, it has a negative effect on your mTOR complex 1, which then just has a downhill effect on the accumulation of cell mass, cell growth, sometimes as far as transition and movement of the cells. So capillary malformations and doing research studies, as you go through the NIH, there are many that are being done. Unfortunately, a lot of these are looking at the end result, the dilated vessels, not necessarily what's getting us to them. So to start out with, we have bromonidine that's been used for a while now as a topical alpha-2 adrenergic agonist. We have timolol, our topical beta blocker, and then of course teleporphin, and looking at can we do better with photosensitizing medications as we use laser for capillary malformations. I'm going to go on to venous malformations, and I said I'm going to work on the PIK3CA gene, and I want you to understand that that provides instruction for the P110 alpha protein, which is the subunit of the enzyme P13K. To me, this is like the Starbucks of the cell. It's pushing it forward. It's what they have to have every morning, just like me. So this subunit, P110 alpha, is the catalytic subunit. So it's making the cell do what it's supposed to do. Well, the other subunit somewhat regulates the enzyme activity. So it's kind of if you've had too much caffeine in a day, you just can't stop your movement. So as we look at P13K, we know that it phosphorylates certain signaling molecules, and that will trigger a series of additional reactions that transmit the chemical signals within the cells. Once again, making this cell proliferate more than we would expect. So we're going to have growth, division, movement, and migration. So that looks at how angiogenesis works and why we see these. Production of new proteins, transport of materials, and then the cell survival, that these cells do not go through apoptosis and continue to live. So when we look at venous malformations, we already talked about the PIK3CA gene. We know that this is found in our patients who have clipotrenalnane and cloves, which is our congenital lipomatosis overgrowth, vascular malformations, epidermal nevi, scoliosis, and spinal anomalies. And if you've had a patient with that disorder, once again, just extremely high morbidity because of the overgrowth. We've looked at treatment for PIK3CA involving sirolimus. Once again, makes perfect sense. BYL719 is a study medication being looked at, especially out in France. And then propanolol, our old favorite that works very well for infantile angiomas. When we talk about lymphatic malformations, we know sirolimus works there also and works very well for that, as similar to our capillary and our venous malformations. When we talk about BYL719 or alpelisib, this is one of our P13K inhibiting enzymes, which is part of the mTOR pathway. So this is an important signaling pathway for, once again, growth, metabolism, translation, and initiation of cells. So for lymphatic malformations and research studies, they're looking at sirolimus and sildenafil. As you know, that's an inhibitor of PDE5. That one I'm not covering quite as much because there's great controversy. As you read the medical literature, there is some literature saying that it's very effective, others that is not. The NIH study is not complete at this point to give us a better answer. Propanolol, so this seems to be thrown at anything red or blue or sometimes purple, and it's to see if it works. And we are finding that it does not work in everything, but this was a recent retrospective chart review, really only involving 7 patients. But this group felt that it was somewhat effective in lymphatic anomalies. They used a dosing of 0.7 milligrams per kilogram per day. They felt if they went any less, it was not effective. And they actually had treated a mother whose child had lymphatic malformation found with ultrasound. Our last topic will be arteriovenous malformations and looking at the RASA gene. This gene will provide instruction for making the protein P120-RAP-GAP. And this protein regulates the RAS-MAPK signaling pathway, if you remember my very messy slide with all the pathways. This transmits the signal from outside the cell into the cell's nucleus, and thus providing reasons for the division of cell, differentiation, and then cell movement. This P120 RAS-GAP protein is a negative regulator of the RAS-MAP signaling pathway, and it's involved in turning off the signals when they are not needed. So the exact role of P120 RAS-GAP is still not fully understood, but it's essential for the development of the vascular system, and you can see why the vascular system is proliferating and going forward when it should not be. So once again, sirolimus is used for arteriovenous malformations. We definitely need a lot more studies to be able to say how effective it would be. We have the kizumab, which is actually first utilized for cancer. We'll go through the cancers that it's FDA approved for, but it has been utilized for arteriovenous malformations at a 5 milligram per kilogram every 2-week dosing for 12 weeks. And this is a recombinant humanized monoclonal antibody that blocks angiogenesis with the VEGF. And as you all know, the VEGF is a growth factor that stimulates angiogenesis in a variety of different diseases, but especially now that we know about RAS-1, our arteriovenous malformations can benefit from this treatment. So this was derived from a mouse, of course, with a monoclonal antibody generated with an immunized 165 residue form of the recombinant human VEGF. By doing this, they humanized retaining the binding region and then replacing the rest of the human full light chain and the human truncated IG1 heavy chain. This was approved in 2004, as I said, a combination standard chemotherapy for metastatic colon cancer, certain lung cancers, renal cancer, ovarian cancers, and glioblastoma multiforme of the brain. And you know, with our vascular lesions, we have been able to learn from cancer and vice versa, and the angiogenesis is so important to both disorders. So as far as arteriovenous malformations that are going on, the NIH has sirolimus, which hopefully will be effective beyond doing interventional radiology, sclerotherapy, and surgery. Hopefully then we can maintain arteriovenous malformations with this medication. There's a plethora of case studies out now with various medications, and it's very interesting to see and exciting because I do feel like we need better studies, long-term studies, much larger patient populations. But as you all know, if you see these patients, the morbidity is so high that the risk-benefit profile does push us to use these medications even when we don't have evidence-based medicine at this point. Thank you for your attention.
Thank you. Our next speaker, also from radiology, to discuss sclerosing vascular malformations is Dr. Abe Wells.
Thank you, Tom. Thank you, Frank and Bahar and Antonio for inviting me to speak with you today. It's been my pleasure to work alongside Joan Tamburro for several years in our vascular anomaly clinic. As you can tell, her information is truly valuable. So today, these are my disclosures, none of which is a conflict with what we're doing today. Today I'll briefly touch upon the classification of vascular malformations, which Dr. Tamburro already has brought up with us. And then we're going to go through the approach I take, the various approaches I use in the angio suite, and the use of advanced imaging guidance for these interventions. ISSO came up with the classification system in 1996 that we utilize here, based on the work of Mulliken back in 1982. Of course, it's been updated since then, dividing vascular anomalies into vascular tumors and vascular malformations. We'll be focusing today on the vascular malformations, on the slow flow venous and lymphatic, and then on the arteriovenous malformations. Over here, what we do is we have a multidisciplinary treatment network. We have a clinic once a month with interventional radiology, dermatology, plastic surgery, and hematology as well. And then we utilize other services to take care of these patients. Most of these patients present with pain, swelling, deformity. It's only the rare patient that actually is looking for a cosmetic result, but we provide that as well. These are the sclerosing agents that typically utilize. Dehydrated ethanol is the most commonly used. It works by directly damaging the endothelial cells, denatures the proteins that leads to thrombosis and fibrosis, and ultimately obliterating the malformation. The other agent we use is sotradecol, a detergent that acts on the lipid molecules of the cells. and causing inflammatory action, thrombus, and sclerosis. When I'm treating venous malformations, I typically mix this with a small amount of Pediatric, usually about a 1 to 1.5. It's about 10 to 1.5 ratio of the sclerosant to the Pediatric. This acts as an emulsifying agent. Additionally, it acts as a contrast agent. So when I'm treating it, I can actually do some imaging and see the sclerosant going through the vascular structures, ensuring that we're not extravasating or causing any other problem. Doxycycline is what I utilize for, there's many agents people use for lymphatic malformations. I typically use doxycycline. I find it works best for my patients. A new agent that people have been starting to look into is bleomycin. It seems to work by damaging endothelial cells and causes an inflammatory reaction. It seems to lead to fewer treatment sessions, but there are limitations on the dose that we can use of bleomycin. A couple other agents which I don't have mentioned here, which are more mechanical agents, such as glue, onyx, coils, particles. Those are more temporizing in cases where the ethanol or sclerosant agent is too dangerous to use. We'll use more mechanical embolization. And we also utilize those agents when we're going to go with embolization followed by resection. We'll start with venous malformations. This is the most common one that I treat. Dysplasia of small and large vascular channels associated with a various amount of hematomal stroma, and these channels may connect with adjacent, sometimes dilated draining veins. We'll start with a gentleman who presented with back pain and a mass in his back area, and if you would notice on the imaging, there's a, do we have a pointer? We'll go through. Oh, I got it. But anyway, you'll notice on the image on the, there's a mass deep to the trapezius muscle. There we go. There's a mass deep to the trapezius muscle on the right side. On the T1 weighted imaging, it's isointense to the muscles. On T2 weighted imaging, it's hyperintense. And then you can actually see layering of fluid within it because it's a very slow flow of malformation. There are dark spots within it, flow voids. These are calcified phleboliths. And so this is a slow flow vascular malformation, either venous or venous lymphatic, based on these images. And if we look with contrast, we see this slow enhancement of the lesion, and as we get more delayed imaging, there's increased enhancement of lesion. So this kind of gives us the diagnosis of venous malformation. There's no high flow within it. There's slow flow, slow enhancement, and it's not cystic because there's enhancement of the spaces. We did an ultrasound and it shows us hypoechoic mass, vascular channels. This is with Doppler. You barely see any flow in it. This is not unusual because when it's so slow, we sometimes don't pick it up on the ultrasound. This is when we went ahead and treated with direct puncture, doing a venogram. We see filling of the malformation. It has a somewhat cotton ball appearance, and we see some draining veins. It kind of also helps confirm the diagnosis. And here it is during treatment. We're injecting sclerosant agent, this time I believe with sotrodecal foam. And here we see post-treatment, just a spot image showing that we were pretty much able to fill the entire lesion with sclerosant with 1 or 2 puncture sites. And this is on follow-up. We see the lesion has significantly decreased in size on the MRI and also on the ultrasound. This is a 49-year-old woman who presented with bluish vascular structures in the right buccal mucosa. She would bite it and bleed from it occasionally, and she came in for evaluation out of clinic. We went ahead and treated it. We used a mouth gag device to expose her mouth to me and the buccal mucosa. We were able to put these needles into the lesion just by direct visualization of the lesion, and venography shows filling in a malformation, and we went ahead and treated with sclerosing agent. A 9-year-old with a bluish tongue mass, difficult to see on the MRI, but if you look at the images here, there's some high signal on the left side of the tongue here, and perhaps on here. And this is intraprocedurally using ultrasound. We see a hypoechoic mass with fluid with vascular channels. This is the needle entering the lesion. Here it is using a butterfly needle. When we get blood return, we do a venogram, fill the malformation, and then we can inject the sclerosing agent. This is just a case that Dr. Mazurek sent me, someone who declined treatment, thankfully. This is a patient, 31-year-old, who presented with symptoms of cold, had a chest x-ray, and the astute radiologist noticed the mediastinal widening on the chest x-ray here, and then a CT scan reformatted here. With contrast, you see an enhancing mass in the mediastinum, anterior middle mediastinum, and superiorly. The patient underwent thoracotomy resection, turned out to be a cavernous lymphangioma on pathology, but then came back a couple of years later with recurrent pain, and here we have a mass in the superior mediastinum. Here it is surrounding the subclavian, left subclavian artery on a CT scan, and this is on an MRI, just showing the different views of the mass. The patient also had some lymphangioma of the spleen. In our angio suites, all of our suites have these 3D imaging technology. We can do cone beam CTs, we can get 3D imaging. In cases like that, it's very helpful for us to target the lesion. So in this case, the patient is now prone and taking a posterior approach. Obviously, it's important that I don't stick the needle in the subclavian artery because I have no way to control the bleeding if it occurs. And so using intermittent cone beam CT images, we're able to get the needle down into the lesion over here and injected the contrast. I think these images are actually after I injected the sclerosant. Thankfully, one needle access, I was able to inject the entire lesion, a nice uniform distribution. The high density material is the lapidol that I mix with the sclerosing agent. So it's nice because it kind of sticks around for a while, and we can see where the distribution is here. The patient had a significant decrease in size. This is pre-treatment, post-treatment. You can see this thing is a lot smaller, but still has some recurrent pain, so we went ahead and had a patient came back again. Again, the patient's prone, this time using a more advanced guidance system because the lesion was smaller. We didn't want to hit the vessel or anything. So using this guidance